Rachel, and we'll be doing a respiratory focus assessment. For the purpose of the video, the patient will have a shirt on. Normally in practice, I would have them remove the shirt. We'll start with the respiratory rate, observing the rise and the fall of the chest as one respiration. Untypical respiration in an adult would be between 12 and 20. For the purpose of the video, we won't count for a minute, but in practice, I would count for a full minute for the respiratory rate. We're also observing the patient's color, making sure it's pink and warm throughout, noting any signs of nail bed cyanosis, any bluish tint to the nail bed, to the perioral cavity, and any generalized pallor as abnormal findings. We want to observe for any accessory muscle use, looking at the patient's supraclavicular retraction, noting any signs of the sternocleidomastoid or the scalene and abdominal muscle use as abnormal. No accessory muscle use is a normal finding, which we note here. We also want to observe for any audible breath sounds. So we're looking for signs of wheezing, crackles, rhonchi, or stridor. So no evidence of those here. We're going to palpate for tenderness and pain. Noting anterior and posterior, we're going to palpate, noting any skin abnormalities anterior and posterior as well, noting any signs of bruising, redness, or rashes. And then we're going to check for chest expansion. I'm going to take both my hands at the level of the 10th rib, have the patient take a deep breath. And I'm going to note even and symmetrical chest expansion as a normal finding. Any impaired movement, the presence or absence of impaired movement, we want to note. We want to note that the chest is always moving symmetrically throughout as normal. We want to look at the structural and symmetry of the chest as entirely, noting that the anterior posterior diameter is less than the lateral diameter as a normal finding, noting no barrel chest here, no evidence of scoliosis or kyphosis. And then we're going to do tactile fremitus. I'm going to take the lateral aspects of my hand, have the patient say 99 with each movement.
99, 99, 99, 99.
And I want even and symmetrical vibrations throughout. And then I'm going to percuss with my left hand middle finger and my right middle finger, noting signs of resonance until I reach the area of dullness. And to find the area of dullness, you're going to go straight down. Note the area from resonance to dullness as the level of the diaphragm. And then I'm going to auscultate. I'm going to have the patient take a deep breath with each movement. And I would go all the way down in a ladder-like fashion. And I would note signs of bronchial, vesicular, and tracheal as normal. Any signs of stridor, wheezing, rhonchi, or crackles as abnormal findings. And then I'm going to have the patient turn around. I'm going to again assess chest expansion posteriorly, have the patient take a deep breath, noting my hands moving evenly and symmetrically, and no presence of impaired movement here. I'm going to do tactile fremitus again with my hands, have the patient say 99.
99, 99, 99, 99.
Noting even and equal vibrations that are symmetrical throughout. I'm also going to percuss again with my left middle finger and my right hand, noting signs of resonance. Any signs of hyperresonance would be abnormal or premature dullness. To palpate the area of the diaphragm, I want to go straight down, percussing until resonance transitions to dullness as the level of the diaphragm, and that is a normal finding. And then I'm going to auscultate, having the patient take a deep breath each time. And then I'm going to move again in a ladder-like fashion, having the patient take a deep breath with each movement. And again on the sides, noting any signs of stridor, crackles, rhonchi, or wheezing again as abnormal, and noting bronchial, vesicular, and tracheal as normal findings. And then for bronchophony, I'm going to have the patient say 99 again while I auscultate.
99, 99.
And I would proceed again down through, going all the way down, all the way through with 99 each time. And noting any signs of abnormal clarity or louder projection of 99 as abnormal findings. And that is the respiratory focus assessment.